Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. David Armstrong. Dr. Armstrong is a professor of surgery at the University of Southern California Keck School of Medicine. He also holds a master's degree in the science of tissue repair and wound healing from the University of Wales College of Medicine and a PhD from the University of Manchester College of Medicine. He was appointed visiting professor of medicine at the Manchester College of Medicine and is the founder and co-director of the SALSA program, which is the Southwestern Academic Limb Salvage Alliance. Dr. Armstrong has produced more than 600 peer-reviewed research papers in dozens of scholarly journals and as well over 100 books or book chapters in his publication history. He is the founding co-editor of the American Diabetes Association Clinical Care of the Diabetic Foot, now entering its fourth edition. Dr. Armstrong is director of USC's National Science Foundation funded Center to Stream Healthcare in Place, which places him at the crossroads of the merger of consumer electronics, wearables, and medical devices in an effort to maximize a hospital-free and activity-rich day in patients with diabetes and particularly diabetic foot ulcers. The focus of our conversation today is to talk about the recurrence of diabetic foot ulceration. We know that a tremendous amount of energy, effort, and money is spent in getting these healed, but it is quite unfortunate at how quickly these recur. There's about a 40% recurrence rate within the first year, with most of those occurring within the first 3 months. At 3 years, the incidence recurrence rate is 60%, and at 5 years, it's 75%. Ironically, 48% of diabetic foot ulceration recurrence is in the contralateral foot, and only 17% of the diabetic foot reulceration is in the same site that the ulcer was, which was previously healed. I think you'll find our discussion very informative as we talk about how activity after the ulceration is re-epithelialized can be properly dosed, and that the patient really should be considered in a state of remission rather than a state of cure. So, without any further introduction, please enjoy this conversation I have with Dr. David Armstrong. All right, Dr. David Armstrong, thank you for joining the show today. And we're going to talk about some pretty cool stuff because you're always doing cool stuff. So thanks for coming on and tell me what the latest is right now.
Well, my gosh, our team are working on everything from, no kidding, spray on and spread on skin to wearable robots to smart boots to smart skin. And I'm the dumb part of the smart part of our team. So it's a fun time to be a foot doctor, man. I'll tell you what, Dr. Barrett, it is such a pleasure to be here.
Oh, thanks so much. So we chatted just a little bit before we came on air about how much effort is put in, and all the things that you mentioned. We're going to probably touch on a few of those because I want to kind of focus on recurrence of diabetic foot ulceration. Because if we discussed everything that you guys are doing, we'd be here for about 45 episodes and still wouldn't be caught up. But anyhow, what dismays me is that it takes so much effort and concerted effort, different disciplines to get some of these ulcers healed up. And then within 3 months, a year, the recurrence rate is really very sad. I think in one of your papers where you were talking about the dosing of activity. That's really great. Do you want to start off by talking about just some of the statistics of reulceration in patients with diabetic foot ulceration?
Sure, Steve. I'm happy to talk about it. Well, actually, to be frank, I'm not happy because there's a lot of bad, but frankly, after all the bad, there's a lot of good. So how's that with the framing?
Yeah.
So let's just talk about the U.S., but we can kind of go around the world. But right now there's actually, we'll just be kind of worldwide here. So there's about almost now 1.5 billion people around the world that have diabetes. And over their life, about half will get some degree of neuropathy. That's an area where you are a world expert in. I know, don't even need to tell the audience that or you that. So they develop some degree of neuropathy. They lose what one of my old mentors, Paul Brand, used to call the gift of pain. And they can wear a hole in their foot, just like we'd wear a hole in a sock or shoe. That hole that is called a diabetic foot ulcer. And that happens now about every second or so around the world, give or take. About half of those wounds over the span of their kind of lifetime will become infected. And from those infections, about 20%, give or take, end up in hospital. And that's why now there's an amputation, give or take, every 20 seconds. Around the world, maybe a little less than that, maybe every 17 to 20 seconds now. And once someone gets an amputation, it's not just a morbid and terrible thing for the family, but there's a lot of mortality involved here because, folks with a high level amputation can see a 5-year mortality be the equivalent of many cancers, like 50 to 80% will be dead in 5 years, depending on what other diseases they have at the same time that they get their amputation with diabetes. So this is common, it's complicated, and it's costly. This problem now costs in terms of just direct costs more than the 5 most expensive cancers in the United States and in Health Canada and the EU and the National Health Service in England. So as we talk about this is this quiet, silent, sinister syndrome. And it's, if you were an evil deity and you were trying to sock it to humanity, you wouldn't pick something like a heart attack or a stroke, something that just seizes someone up and knocks them down. You wouldn't pick even something terrible like HIV/AIDS, or you'd pick diabetes, right? Because it's quiet. People have silent heart attacks. They have silent leg attacks, and that neuropathy is what is so sinister about it.
So, I mean, there's a lot of variability in statistics when you look at these different papers, and I don't think it's necessary to be that precise. If it's 40% or it's 35%, it's still a very bad problem, and it reflects the global difficulty of this problem. What do you think, in your current understanding of all of the data, that the true recurrence rate of diabetic foot ulceration is?
Yeah,
is it about 40%.
It depends on what time frame you're talking about. So let's just do this with the best available data we have, and these data seem to be kind of consistent. At 1 year, about 40% of folks will develop another ulcer after healing that wound. So healing these wounds is one thing, and it is not easy. It's easy to talk about on a podcast. But it's not easy to do in real life. But it's and there's so many things that we can do to help people heal by good quality debridement, by surgical and medical and mechanical offloading.
Right.
And we got so many things going on there. But those kinds of things, take a long time to heal someone. But once someone is healed, let's just say, thank goodness they're healed. are they really healed? Because at 40% will recur in 1 year. And a lot of that happens in the first few months of the year, but it goes out to the year. It's about 2/3 at 3 years and 3/4, give or take, at 5 years. So folks with diabetes, we use the term healing, but we compared this problem to cancer just a minute ago. And, we think that maybe a better term and a more humble term here might be to use the term remission to speak to this. And, when you say that word remission, people understand that. They understand that, if you're a patient, you could say, thank goodness I'm healed. But if you hear the word healed, I would make this, I'd check it off the list and I'd make it 11th on my 10 most important things to do. There's a lot more important things to do than to worry about something that's not hurting you because of the neuropathy and has already been checked off a list. So, and I'd jump out of the chair and I'd walk out of that doctor's clinic in the same, sometimes in the same shoes that caused the problem in the first place, right? Or with the same activity level. But if I hear remission, then you're thinking, well, it's darn near certain that something's going to happen over the next, 4 or 5 or 10 years. But in my long life with that patient, with that doctor, I want to be, there's maybe some things that she or he can do for me that might help me extend my days without an ulcer. We call it ulcer-free days, right? And so even though I'm going to get another sore, maybe that sore is going to be relatively uncommon and relatively uncomplicated, and it's not going to wind me up in the hospital. Right. And so that is the big idea. And the good news is now I think there's a lot we can do for these patients to do that, to maximize those ulcer-free, hospital-free, and activity-rich days, if you will.
Yeah, and I think that we're going to talk about that a little bit, but I think there's a lot of power in nomenclature, and positive and negative. But I think the fact that you guys use the term remission is very powerful because, like you said, it creates a different mindset. I mean, and the other point you made that we should follow up on just a little bit is these are very difficult problems to treat.
Sure.
The manpower that goes into getting them well. Well, I mean, I've seen where it's and these vary from patient to patient. Obviously, it's tough to make generalizations and stereotypes because every patient is individual and different as far as their vascular status, how much neuropathic status is present, that type of thing. But generally speaking, it's 13 weeks to 26 weeks to get some of these very difficult ulcers to heal.
Yeah, if you look across the United States, we can go around the world too, but if you look across the United States with the best available data in registries, now this is not looking at special studies or anything, but if you look at what is reported to these registries, what we see is that at 12 weeks, let's just say 12, around 30 to 40% of these patients are going to heal at that point, at that time.
And that's epithelialization.
That is defined as healing based on what the doctor says is healed. Right. So even though if we look at many studies in the literature using a certain kind of dressing or technology or technique, that number can be much higher than the 30 or 40%. That's what we see right now. So there is as one of my friends, Caroline Fife, in a manuscript she wrote, there's a fantasy of what we think as doctors we're doing, and then there's a reality, and the reality is worse than I think what the fantasy is about the percentage of people being healed every week. Although, again, individual centers can do a heck of a lot better over that period of time. It's hard to get these patients healed, but after that, you can add a lot of things to this to help them get healed. But those are the numbers right now around the United States. And that's pretty similar in various places around the world. Centers of excellence that really focus on this do better. Centers that use good quality devices to protect the foot and do good quality surgical intervention on the patient to clean up the wound can do well. And then those are often centers that also use some of the advanced, so-called advanced healing modalities like special kinds of biologics, or certain kinds of methods of skin grafting, or certain kinds of technologies that are kind of engrafting onto an area that could help kind of move the wound forward in a way that maybe fertilizer, if you will, might help your landscaping grow a little bit better. But without the good quality stuff on the front end, what we take off, things like the pressure and surgically cleaning it up, what we put on the wound doesn't matter as much, because you can put whatever you want on many of these wounds. If a person is unknowingly destroying it when they jump out of the chair with their first few steps they take because it's not being protected, well, that's just good ideas and good energy after bad.
Right. So the way I look at this conundrum is that a lot of patients who are diabetic, as you point out in some of your writing, they're very fearful. Like one of the greatest fears of when people are diagnosed with diabetes is ulceration and potential amputation.
Yeah.
And
sorry to interrupt you there. Sorry, not sorry there, Dr. Barrett.
Go ahead.
But listen, so just to go on to what you're saying there, you are so right in that, one of my friends, Dane Wukic, had a couple of manuscripts along with his entire team, but suggesting that people with diabetes fear amputation, believe it or not, more than they fear death. How's that? I mean, and so if you ask people what they're afraid of, many will say, I'm afraid of going blind with diabetes. I'm afraid of going on dialysis with diabetes, and I'm afraid of getting an amputation. But believe it or not, they fear amputation when you ask them more than they fear death. So because, there's something, when moving through the world with both legs is something that is deeply, human. It's what makes us human. It's what makes us different as kind of hominins, as it were, if you're an anthropologist, from other, primates, as it were, who were kind of tree dwellers. And you take that away, right? And it makes you feel different. It makes you feel, I'm not going to say it makes you feel less, because it shouldn't, but it does. Right. And so taking that away and taking that ability to move through the world away is something that strikes us very, very primally. And it should. The cool thing is, if you will, if there's anything cool or good about this, is that there's a lot we can do to help on the front end to prevent that. But then even after an amputation, there's a lot of things we can do to help people move through the world better on the back end, and then somewhere in the middle too, for a lot of patients to try to get them to move through the world better.
All of the sponsors of this podcast are listed on the website at potofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000. But you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been. Yeah, I think that's really an important point. And what I was going to what I was going to say is that because of that fear, I think there is a subset of folks that once they get this diagnosis, they're very vigilant and they really are in the prevention mode, mentality, for lack of a way to put it. Well, then let's say the poor individual develops an ulceration. Now we have this extensive and very expensive treatment to get them healed. And then phase 3 would be the prevention again of the recurrence. And that's where I'm really interested in what you guys are doing, because you talked about the dosing of activity. And I think that's really great because the way you put it in some of the papers you've written is very understandable, like step count, these types of things. I think that's wonderful because it's great. The greatest thing is to never get the disease or to never get the disease back again. And that, I think, sums up why I wanted to talk about this recurrence aspect so much. Talk to us about that a little bit, because you all are using some really cool monitoring. And So
and the great news here is a lot of it now, thank goodness, over the years has become less and less expensive, or even more or less free in some cases, which is pretty awesome. I mean, but let's get into some of that, and you can remind me to bring some of this stuff up if I forget. But first of all, let's get started with just maybe monitoring yourself in the most basic way afterwards, because again, remember, this is 40%, 2/3, 3/4, at 1, 3, 5 years. So the chances of you getting something, if you have diabetes, again, after healing, is very high. But one thing you can do is stay in touch with your specialist, with your foot doctor. And one thing that we found to be very, very helpful is to give clinicians and patients a kind of an avenue to where they can communicate. And we have a program that was started here at USC at our Keck School of Medicine with both me and one of my really clever medical students who spent, I think, 5 years doing research with us. He just matched last week for dead plastics at Georgetown. So Mark Swerdlow's his name. But we developed a program that we called the Foot Selfie Program. Okay. And this is super easy. It's just like it sounds. People just take a picture of their feet. And Mark made a really clever, very inexpensive 3D printed little platform that you could put just your phone on, and a little app where someone could just say photo or take a photo, and it'll automatically take a photo. And actually, some of our patients who are blind actually take the best photos, believe it or not. You won't believe it. Huh. It really is amazing. But you can also do this a whole bunch of other ways where people just get a good enough photo of the top and the bottom of their feet. So that's a foot selfie program. And we actually have within our unit foot selfie rounds once a week, like 7 a.m. on Mondays. Right. And, not a week goes by when we're evaluating them where we don't identify a person that's at high risk and prevent a hospitalization. And it's so fast. You can get through 100 photos or something just manually, in just about 10 minutes or less. And what we're also adding now, and we've been playing with this, and it's not just us, it's some of our partners and friends like Moy Hoon Yap and others in Manchester. We've been developing what's called now Diabetic Foot Grand Challenge, which is where there's an award to be given to folks who can autonomously develop an algorithm to autonomously identify a wound that's about to happen in under 10 seconds. Wow. And so that's the challenge. And we already have a lot of these data published in libraries for deep learning, for AI-based algorithms to do this. But I would imagine very soon clinicians are going to have a Sherpa, an AI Sherpa, kind of your GPT-3 for toes, or that will kind of sit side saddle, or I should say, in the sidecar to be looking and helping you identify this. Right. But even without that, it's something that's basically free, except for time, the time that it takes for you to do this. So that's pretty great. So so on that end, I'm actually very encouraged. On the other end, so that's the foot selfie. But then the next question is, well, what is it that causes these ulcers to recur? And one of the most common things is, well, it's repetitive stress that causes people to develop inflammation and then to develop a wound. So what we have seen in study after study after study for many years is that wounds tend to heat up before they break down. So you may be able to identify that ahead of time. And what we have seen that is really helpful is just using very inexpensive thermometry, where someone can check skin temperatures and dose their activity by doing so, by checking their skin temperature, just as they might dose their insulin by checking their glucose. So these thermometers, if you will, or these sensors are like glucometers for your feet, for your activity. And this has been an analogy that I've used probably for 30 or 40 since I was training. And it's a thing now, and you can go on and just grab something on Amazon now and for a thermometer and use that kind of manually. And it's extremely inexpensive to be able to do that. But you can also get more sophisticated tools and technologies that you can stand on, like bath mats. There are also smart socks that you can use. There are smart insoles, a lot of smart stuff that's happening that does it, that do that even better, and that analyze it even better, and that can give you and your doctor some more information, a doctor or nurse. And there might even be, through some of these, like almost like, operators standing by, to where they can identify something, and then it would go to maybe the equivalent of a call center with specialists that can identify something and then alert you of, hey, your big toe's harder than your other big toe, and you've been taking a lot of activity today than you usually take. Why don't you, chillax a little bit, if that's a thing. Right. And we're going to see that appointment with Dr. Barrett in a couple of days. So, that is a thing now. Right. And there are businesses, companies that are monitoring, that are being built based on this. And it's really exciting because you're starting to see identifying these areas of potential re-ulceration in remission, not just hours in advance, but in some cases, days and weeks in advance. And so that's pretty great. So so that's the other thing, is dosing activity. And one of the other things that's been developed by our team, and from Mal Fernando to Virginia Blanchette to Stephanie Wolfel on our team, we actually have just a simple calculator. I think we've even published this, that you can use on just an Excel spreadsheet, where you put in your activity and it will give you a little, it'll just sort of train you up and kind of move you up into to increasing and improving your activity in remission, so you don't kind of reach a kind of a too high a threshold or too low a threshold, just like dosing a drug. When we dose a drug, we have sometimes what we call a peak and a trough. And the peak, sometimes you might have toxicity. So if you're taking a drug like an antibiotic, it might affect your liver or your kidneys or something. Right. And you could have toxicity on the high end. If it's too low, you don't get the benefit of the drug. With activity in diabetes, too high, and you might develop an ulcer, right? Too low, and you might not get the cardio-metabolic benefit of being active. But there might be a really big range of activity that's just right. Right. Kind of like the three bears.
Call it the therapeutic window.
Bada boom. There you are. Yeah. It is the Barrett therapeutic window.
There you go.
Window of Barrett.
Well, whatever. But one of the things that I wanted to really focus in on was there's this perception of, when we discuss recurrence, that it's a very high percentage in the same site. And in fact, it's not. And so, so that, I think, is something that there's this universal misperception from patients that, I only have to look at this one spot because that's what they healed up. It's like, no.
Or the doctor or nurse or the therapist perception. All of these, we all think of that.
Yeah. And that's something that with the monitoring, you're looking at both feet, you're looking at these pressure areas, you're looking at temperature increases. So,
in fact, you're referring to this, and thank you for reminding me, because I think we had a manuscript. It was either last year or the year before, something like that. These years, they all kind of
they go back.
The peri-pandemic time dilation.
Yeah,
maybe it was 10 years ago, or just last week. But a recent manuscript from us, a study, we saw that, and it really the data surprised me. I thought it would be high, but I didn't think it was going to be this high. But it was, basically, let's just say, the dramatic most of reulcerations that occurred, like 8 in 10 happened in another site away from the spot that originally ulcerated. And so then the other thing is, I think about half, give or take, were on the other foot. So as we're watching the one spot, it's like we've been
neglecting the others.
It's been a fake, and it's no one's fault. It's just human nature. We were going to look at one thing, but and that's the other thing. Back to all the other things that we were talking about on the big end. We as humans are really good at reacting to emergencies. Mm-hmm. There's a horrible tragedy, there's a fire, there's an accident, and we react, right?
Right.
But there's a sound and we turn our head. But what we're not good at, what we are just not programmed to be good at, are slow, silent, sinister things. And that's the trouble here. And what we have to try to do with these non-communicable diseases, and the diseases that are part of the diseases, like with diabetes in the foot, or with cancer, or with cardiovascular disease, or with pulmonary disease, things like this, these non-communicable diseases, we have to figure out ways to alert ourselves, meaning patients, clinicians, healthcare systems, without totally turning us off, right? How do you ping someone without just getting them to say, forget this is driving me crazy, and they take it off? This has been a part of our universe forever. And we have an entire big NIH study right now where we're trying to do this through a smartwatch, trying to get people to use a device to protect their feet more with wounds. And it's how do you do something with someone and not to them? How do you not force them into it, but how do you do it with them? This is not easy.
No.
But we can learn, I think, from the women and men working not in medicine or in engineering or in surgery or in basic sciences, but people working, believe it, but I think maybe people working in marketing. How can you get someone to do something, not that they shouldn't be doing, but get something that they know that they should be, or that to keep them alerted about it without making it occupy their life.
Right.
But so that's pretty great. I mean, that's an exciting time, and it's an exciting time to be doing this. Almost like a fire alarm for their life.
Yeah, and I think you make a very valid point about humans. We do react to crises, but we're also very cognizant. But I think this cognizance of potential is sometimes relegated to the back burner, for lack of a way to put it. An example in real estate. All right, let's say you're laying in bed and you see a little spot on the ceiling that's indicative of maybe a real slow water leak. It's like, watch that spot a little bit. Doesn't do too much, but a year goes by and now all of a sudden it's an inch in diameter versus a drop in diameter. It's not big deal. And then one day the whole roof falls in on you. And it's not that the roof collapsed that day. That roof collapsed a decade ago when this process started. So I think you're absolutely right as far as motivation. And I think maybe the only way to maybe overcome some of that hurdle is empowerment by knowledge and education in a format that is palatable and not Like, I've had enough of this. Don't tell me this, and that there's a lot of magic in that. So,
listen, you had me at hello here, man. I agree. I want to get on that train because this is, but as I told you, I think this is a time right now where so many of the things that we have been working on, kind of toiling in isolation, is starting to become more widely available. And we're starting to see even more data support all this stuff. And we're seeing the inexorable merger of consumer electronics and medical devices on us, in us, right. And the masters of the universe, I think, are going to be the women and men that can make all of this stuff talk to itself and talk to us as patients and us as doctors without overwhelming us, and letting us know what's important, so we don't have like a paralysis of analysis.
Right.
So there you go.
Yeah. No, you're right on. I think one of the things I've come across in our work in neuropathy and that type of thing is this pressure-induced vasodilation, which is a concept that I think probably plays a hell of a big role in reulceration. And
yeah, well, let's develop that, man. So on that note, what we've been finding actually, and you should actually interview Bijan Najafi, Najafi. Just Google him, ladies and gentlemen, in your PJs. So Bijan's my old longtime research partner, and he was a junior faculty when I hired him 20 years ago in Chicago. But he's a full professor and just a great guy. Just got a Lifetime Achievement Award last week in Washington, D.C. But Bijan and we found about 8 or 9 years ago now that it was fascinating. It wasn't just the number of steps that people were taking that seemed to predict non-healing and ulceration, but remarkably, it was standing. And so it made it sort of unprotected and even protected, but mostly unprotected standing. And so what we started thinking was, Stephen, is that maybe, just as you're saying, maybe it's like a little ischemia reperfusion injury that we're seeing in this patient population. And maybe you ought to explore that, in patients, but also in research, maybe, and maybe in the podcast with him in a future episode. Go for it.
Sure. Well, I'd love to do that. I think that, the body is so miraculous. The physiology is phenomenally extraordinary. And the more you dive into it, the more you realize this is, it's a system that took a heck of a lot of engineering. And when you think about how the deep capillary network will shunt blood to the superficial capillary network based on, this pressure-induced vasodilation, that's a really, if you think about it, how sophisticated is that?
I'm telling you, man, you are so right on that. I just definitely, I think there's something to this, and so I would definitely pursue that if I were you. You're already doing that, but I think it's important.
Yeah, and I think where I've got to take my hat off to you is that you have done, the body of work is just incredible, and you need to be lauded for that in and of itself. But we tend to get a hammer and identify everything as a nail. And we know that human physiology is not a nail. There's all kinds of other things that your hammer is not going to work on. And so I think, you need to take a more of a global approach with this, and not everything is this or everything is that. Like you made the point with biologics. You can have the greatest biologic in the world, but if the pressure is overwhelming at that spot, doesn't matter what it is.
That's right.
So you have to integrate all of these things. And I think that's what you guys have done really well with your your team approach and that type of thing. And
that's the point. Sorry to interrupt, but you mentioned the team, and that's really what it takes. It's one of these things where it's no clinician, right, is unto herself or himself an island, as it were. Right. It really does take a team to really make a difference here. And that's been really the single most important thing we've seen over the years, is that bringing people together. And we call the team that we have the toe and flow team, when you bring podiatric and vascular surgery together on one service. And then when you add things like physical therapy, or if you're British, physiotherapy, we call it toe, flow, and go as part of that too. And those kinds of things have been, I don't want to use the word game changer, right? Because it's overused, but I'm going to say game changer, because those, when you do that, that's a way forward.
Yeah, and I think that that's the way this has to be approached. I mean, even our pain patients, we're looking at, how can we increase their metabolic function, make them less insulin resistant, just make them better humans. And it's amazing when you optimize the human, we have less of these symptoms that we have to treat. So I think that, it plays a big role in it.
That's it. And that's another thing, we could go on about how, we don't have time to talk about, nutrition now, but I think we used to just maybe sort of blow that kind of thing off.
Right.
Most clinicians don't have a lot of training, even though we think we do, or we say we do in nutrition. And but our friends that are our registered dietitians can be like other spectacular partners in this. And I think that's only going to grow in the future in these interdisciplinary teams. But, what our patients are putting in their bodies, we are, when they leave the clinic, right, that's not a medicine, but it is more important than that. It seems so simple, and we could just write a prescription for it. But that's ridiculous. It's it is, and we just blow it off, and we wonder why sometimes the results that we're getting are not as good as we could. And then that often points to all kinds of other social determinants of health that are blocking the way, that don't really reach us when we walk into a clinic room with our patient, as much as we care about that patient. So anyway, there's just so much more to talk about.
Well, yeah, no, but you're preaching, to the choir, because, when we first started in the early 2000s, looking at, peripheral nerve decompression, these things that you and I have had chats about before, I realized very quickly I only had a hammer and I needed, some other tools. And you almost got to this point by default, because it's like, okay, great, I got a partial result, or I got a great result in this person and not in the other. But well, what am I dealing with, right? So if I was an artist, could I expect to make a great painting on multiple different types of canvas, where one is rotten and not going to accept the media that you're putting on it, and another is a great canvas? So we were forced to kind of look into this, like, wait a second, we have to look at the treatment of the core physiology of this patient to maximize anything that we're doing. And a lot of times what would happen is we would maybe try to optimize some of these patients for surgery, and lo and behold, they resolve their problems. And so I think it even says more to the point when we're dealing with the diabetic population, because, in a perfect world, we should be able to stop the development of this disease in many, many patients. And we know that we can reverse it in many patients. I mean, look at the studies with gastric bypass surgery, this type of things. It's like, so it's a disease that's a horrible disease, but it's not horrible in the one aspect that many times it can be reversed or prevented. And unfortunately, that's not the case with a lot of other things that affect humans.
Yep. You got it right.
But so we're going to monitor their pressure, number of steps, their activity. We're going to titrate that up over a period of time. What else am I going to do for this patient that we've sent to you, got successfully healed at the limb preservation experts? And now what can I do to make sure that this patient doesn't end up back under your service for as long as possible, or maybe never?
I think that the best way forward really is, well, first of all, I would say nothing ruins a good result, surgically or otherwise, like follow-up. That's what I always tell my trainees in the OR. Or ultimately, however good we think we are in the OR, in the operating room, or in the clinic, or just anywhere, ultimately either our repair is going to go down, or the patient will, or both. And so our goal, the real idea, is that this team, which includes all the other members of the team, because, just should be there for that person when that happens, right? And so they got to know that it's not just like a hit and run, procedure, or just a visit. It's like it's from the alpha to the therapeutic omega. And if you can follow people over the course of that, then that's where, and when people know that you're there for them,
right, then
that means something.
Right.
And my pop used to always tell me that, my dad was a foot doctor, and I grew up kind of in the office, and now my oldest is going to be a third generation foot doctor, by the way.
Congratulations.
God dang. My dad used to tell me that, he said, son, folks don't care how much you know until they know how much you care. And I used to roll my eyes back then when I was like a teenager. I thought that was like just like belong on a poster or something.
Right.
But it's true. People know, your patients know when you're there for them, and they know when you're just dialing it in. And they can tell, and just like, that. And so even if it's only for a few minutes for a visit, they got to know that that's the case. And you got to know that's the case. And that is like, that's what makes this whole work worth, if you will, like a life's work.
Mm-hmm. Well, you certainly have proven that, and are continuing to prove that. I can't think of anybody else that has done even close to what you've done, not only in this space, but really in any space. One of the things that I just wanted to add, as far as what we've seen that I think can empower patients to follow your regimen that you recommend, is biomarkers, data points, metrics. Yep. Because if a patient can see a scoreboard, they know if they're winning or they're losing. And one of the most powerful things that we've found, and I've actually done it myself, is continuous glucose monitoring. And so when you're talking about, well, you maybe shouldn't eat this, well, that doesn't mean that much, except you're the guy blowing hot air in that clinic room that day, telling them not to eat that. But when they see that monitor go crazy after a bowl of ice cream or whatever, it gives them this feedback that's like, oh, wait a minute, maybe. And I think that can affect behavioral change to a degree more than just, chatting with them about it.
Yeah. I couldn't agree more. And so you could be using glucose on one end, and then imagine on the other end, like we talked about, you're using activity and kind of temperature and other things, biomarkers, because the two, and then for us, the two could be running simultaneously. I think that's gorgeous, really elegant way forward. Yeah, and you're right. Yeah. When we were in the early days of continuous with the CGI, continuous glucose, measurements for these patients. What we used to be doing in that population is we'd see these wild swings that we were, especially when they left the office, right, or the clinic, and that we wouldn't see in just the one or two visits or the one or two measurements a day. Right. We used to call that an M value, but that kind of thing, I think you see in a lot of areas if you're doing continuous measures, and how important that is with things like thermometry and with activity. It's unclear right now, but certainly with glucose, we've sort of seen that, and being able to level that thing out, because again, you can't manage what you can't measure, and and we, I think, in medicine, talk about measuring things all the time, and we just still, for the most part, we could do a lot better. And especially in this area. In fact, just before talking to you, I was on with some of my friends and partners from one of my vascular surgery partners, Ziwe Tan, and then a couple of guys, Evan Raffin, from the Department of Health Services. And what we're trying to do is to develop a dashboard, if you will, to be looking at the how we can be following these people across our whole Los Angeles County. And Dave Engel is a doctor that helps to run some of these things at DHS Central. And so within Los Angeles County. And so, we have 10 million people, 10.1 million, give or take, in the county. And, tons of people with diabetes, and try to do that. So both writ small with our individual patients, but also writ large, there might be ways that we can start looking at this. So it is really, really important.
That's very cool. Well, I want to thank you for taking the time to come on. And I always get energized whenever I have the ability to interact with you. And I hope we can do more in the future. I really love what you're doing, and our profession loves what you're doing too. So,
well, man, the feeling is mutual, Dr. Barrett. I tell you that right now, for real.
Well, I just like hanging around with smart people like you. So that's my goal.
I thought you meant smart people and me. So,
no. It's like my goal is always to be the dumbest guy in the room. So,
well, you try, I succeed. So how's that?
Yeah, there you go. All right. Thanks so much, Dr. Armstrong. I really appreciate it. And let's do some more education.
Onward and upward, Dr. Barrett.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.